So today we are going to be talking about depressive and bipolar disorders. And again, this is a focus on children and adolescents, chapter 10 in your textbook. And I want to just start by saying, of course, we know that depression is seen right across the age spectrum. So we know that children do experience depression. We know that adolescents do, certainly young adults and adults do, and even the elderly do. And so what's interesting, of course, is that the DSM-5 criteria for depression remain the same regardless of where you are in the spectrum. But remember that we always are thinking about, is this quite different from someone else of the same age, same gender, same scenario, same situation would be facing? What we also want to keep in mind is that it's quite difficult to detect depression and to diagnose depression and to identify it in children under the age of 7. A big part of that has to do with the fact that our understanding of depression has a pretty big cognitive component, and children that young either are not capable of thinking in those ways or are unable to express that they're thinking in those ways. So that can make it a little more challenging. Plus, children may manifest and exhibit behavior that's different from what we're expecting to see with depression traditionally. So I just want to sort of start with that and to remind you of that. And so the way I want to sort of lay things out today is we're going to start with just a review of the different diagnoses of the mood disorders, so both the depressive and the bipolar. And then we're going to shift gears and watch a movie. And I know you might be thinking like, okay, Carrie, this is like the third lecture in a row that you're having us watch something. And I would be doing the same thing in class. I think that particularly for the movie you're going to watch today, it's a documentary. And I'll say a little bit more about it when we get to it. It's quite difficult to watch, so I do want to give you that forewarning. But I think it's really, really important to see, and it's going to convey things to you in a different way than I could just through lecture and readings. So that's where we're going, and I think in some ways, I think there are challenges to watching this movie on your own. I think there's something about the collective experience. But I also think that because of how difficult the content is, that there might be some benefit to being able to watch it at your own pace, on your own, and to feel what you feel without being sitting in a public setting. So at least there's that. And then after that, we'll talk more about, the impact on the child and the family and all that stuff and the causes and treatment. So to start with, when we're talking about mood disorders, we have both our depressive disorders and our bipolar disorders. And in terms of depressive disorders, we've got the three. So major depressive disorder, which of course is sort of our big one that we talk about a lot, that all of you should be familiar with from PSYC 2285, from Abnormal Psych. And of course, you can look at the diagnostic criteria in the textbook. So it's page 316 in both the 6th and the 7th edition. I'm not going to go through it because, again, I'm expecting that you're familiar with it, but just again, remember that it's quite a lot of symptoms and symptoms that could present in different ways. So we can have two people who both meet the diagnostic criteria for major depressive disorder who only truly share one symptom. So it's just important to remember, especially when we're talking about children, that children may present quite differently and quite differently from each other, even though they're both going to meet the diagnostic criteria for major depressive disorder. Persistent depressive disorder is the new name for what used to be called dysthymia. And so again, persistent depressive disorder is that sort of lower level depression that's kind of always there. It's there more often than not, more days than not, and for a duration of 1 year in children prior to diagnosis. It's 2 years in adults. So this is one of the few diagnoses that is different in terms of one particular criterion, which is the duration. And that kind of makes sense, right? Because when we think about an adult, if we're taking someone in their 20s or 30s or 40s, saying that they have to have been experiencing this persistent low-level depression for at least 2 years prior to diagnosis, that really gives us a sense that this is something that's long-standing and going on. To say to a 12-year-old that they have to have it for 2 years before we diagnose it seems a little extreme. So the 1 year limit for children does make quite a bit of sense in this case. And again, it's different than just a bad mood, or it's different than just being sad because of a circumstance. So it is that low-level chronic depression that people can experience. And then a new disorder to DSM-5 is disruptive mood dysregulation disorder, which is essentially a fancy way of saying inappropriate temper tantrums. But inappropriate temper tantrums doesn't sound like a great diagnosis, so instead we have disruptive mood dysregulation disorder. And basically, these are temper tantrums that are age and situation inappropriate. Excuse me. Tends to be children and adolescents who exhibit an irritable or angry mood. And this diagnosis came to be in a large part to try to reclassify children who were being diagnosed with bipolar disorder. About 10, 15 years ago, we started seeing a surge in children and adolescents being diagnosed with bipolar disorder, enough that it made the psychiatric, psychological, medical community sit up and take notice and say, wait a second, are we sure that these children are actually exhibiting bipolar disorder? Or is it something else? And with further study and sort of looking at what the symptoms were, a lot of these children and adolescents were being diagnosed with bipolar disorder because that's what fit best. They met the diagnostic criteria, but what they were exhibiting didn't have the feel of bipolar disorder. By introducing disruptive mood dysregulation disorder, we're able to capture some of those children so that we're using the bipolar diagnosis when a child actually has bipolar, and then using disruptive mood dysregulation disorder when it's more appropriate to do so. Disruptive mood dysregulation disorder does have some age parameters around it. So again, an adult who is exhibiting these inappropriate temper tantrums, we would not be considering disruptive mood dysregulation disorder. This really is a disorder of childhood and adolescence. And again, it's those age inappropriate and situation inappropriate temper tantrums that we see, and again, that are happening on a regular basis. They have to be somewhat persistent. They have to be causing distress and impairment. Those are always factors in our diagnoses. And then we have our bipolar disorders. That should actually have an S on the end. It should say bipolar disorders, not bipolar disorder, because we have bipolar 1 and bipolar 2. Bipolar 1 is when a person does exhibit and experience a full-blown manic episode. So again, that's that period of elevated mood. It could also be some anger, irritability in children and adolescents, but it persists for at least a week or less if the person is hospitalized. And that's that needing little sleep, talking really fast, lots of ideas, lots of productivity, really, really quite elevated from their normal experience. Bipolar 2 is diagnosed when a person experiences hypomanic episodes. So those are still more elevated mood and energy than usual, but it has to last 4 days or more. It could last longer, but it doesn't have that same sort of grandiose feeling that a full-blown manic episode would have. And again, for a diagnosis of bipolar 2, the person has to have a depressive episode as well. Bipolar 1, as you hopefully remember from 2285, can be diagnosed on the presence of a single manic episode ever. Most people do experience depressive episodes as well, but that is not strictly required for the diagnosis because the manic episode is so elevated from their normal experience that that's enough. But a single hypomanic episode would not garner a diagnosis of bipolar 2. It has to be at least one hypomanic and at least one depressive episode in order to get the diagnosis. Okay. So the video that you're going to watch now, I want to just sort of preface it a little bit before you go right over to it. It's called Boy Interrupted, and it was an HBO-produced documentary. What is fairly unique about this is that both parents are filmmakers. And so they ended up having a lot of footage of Evan and were then able to put this together. So it's sort of a really unique situation, and when I first stumbled across it, I was just mesmerized and thought, this is amazing. It's very tough to watch. It is a documentary, and it is very, very personal. It does deal with suicide, so I'm just putting that out there. But I think it's really important to watch. It gives us a look at depression and bipolar disorder in a child who turns into an adolescent. So we really get that full spectrum of what we're talking about with both of these disorders. And we see the child, we see him turn into an adolescent, we see his siblings, we see his parents, we learn about family history. There's footage of his friends being interviewed. And so I just think I can't possibly describe these disorders and the impact as well as this video can. And that's why I am choosing to use it, and that's why I'm asking you to get uncomfortable and watch it. Again, this is something that you can access through Films on Demand. That's the streaming service that has this one. So again, if the link doesn't work, because Film on Demand links are often quite fussy, just go to the MRU Library website, search for Boy Interrupted. You'll find the video available to stream through Films on Demand, and you need to be signed in using your MRU credentials. And when you're done with the video, come on back. And of course, there'll be a reflection question, because of course. So actually, this time I'm being a little tricky, and I'm giving you questions 1 and 2 based on this video. And again, we will spend quite a bit of our discussion time talking about it. So the question 1, while Boy Interrupted is very hard to watch, do you think it's worth showing again in this class? Please explain your answer. And reflection question number 2, who in the video were you most bothered or angered by, and why? And I'm really curious about that, because my personal answer, which I will share with you in discussion, is not really one of the central players, if you will. And I actually kind of have 2. So but I'm asking you to only give me 1. You can give me a second if you can squeeze it into your 6 sentences. But who were you most bothered or angered by, and why? And now Ian has another video to add to his watch list. Maybe. Okay, so let's talk about the associated characteristics of depressive disorders. We're going to see in children and adolescents who have a depressive disorder some intellectual and academic functioning challenges, in part because it's really hard to concentrate. When you're experiencing a depressive episode, it's really hard to focus on stuff. And so these are children and adolescents who will have a difficult time concentrating in school. They'll have a difficult time concentrating when they're trying to do homework or read things or even watch things, right? So that is going to lead to some academic challenges. They also might have decreased interest in things. That's one of the things that we often see as one of the symptoms of depression, that you just sort of aren't interested in stuff anymore. So you're not interested in your friends, you're not interested in sports, you're certainly not interested in school. Sometimes all you're really interested in is going to your room and going to sleep. IQ is unaffected, so a person's intelligence, their overall intelligence quotient, is going to be unaffected by depression, but their achievement is going to be affected. And so you might remember from earlier in the semester, we talked about those achievement tests that we can administer, that we use in conjunction with IQ tests to diagnose like a learning disability, let's say. And what we'll see is not necessarily on the standardized test, but we will see just overall achievement. When a child or adolescent is in the throes of a depressive episode, we'll often see their marks go down, their performance on exams be poor. They don't care. They don't have the capacity to invest in concentration and memory and studying the way they do. And they're so down that a bad grade just piles it onto the other things they're feeling bad about. So we do see that dip in academic functioning, typically with a depressive episode. We'll also see cognitive biases and distortions, and these are a little bit of both cause and effect, right? So when a person is experiencing a depressive episode, it's fairly common for them to experience feelings like helplessness and sometimes hopelessness, and then to see everything through that lens, right? And that's that cognitive bias. It's the like, I'm never going to be good at anything. When it's like, no, there are still lots of things you're good at. you might not be having a lot of success in feeling good right now, but you're still good at all these other things. But that cognitive bias, it's like that dark lens that you put over your face and you see everything just with these deepening shades of gray as opposed to seeing life in color. Excuse me. And of course, these biases and distortions that also feed into those other symptoms of depression, so that helplessness, hopelessness, lack of ability to see other possibilities in the future, lack of interest and motivation, and just that feeling of, things are never going to get better. This is how I'm destined to be for always. We'll also see some negative self-esteem, which again can also be a symptom of depression. Self-esteem, of course, really develops quite a lot in adolescence, and so this negative self-esteem tends to be a pretty big symptom for adolescents experiencing depression. So just really not feeling good about themselves, not feeling certain about themselves, feeling like they're incompetent, not good at things, not going to find a way. We'll also see with children and adolescents some social and peer problems as a result of depressive disorders. They often will feel quite isolated and be withdrawn, and then of course they'll say, well, I don't have a lot of friends, I feel really isolated. And it's like, well, if you're always withdrawing into yourself, it's very hard for people to reach out to you. And what I often think about is when a person is experiencing depression, right, their friends, and so particularly for an adolescent, friends will be like, hey, we're all going to this party. Well, okay, in a world where parties used to exist, that doesn't exist anymore in our current pandemic reality, but we're going to this party, or we're going to hang out at the mall, or we're going to a movie, do you want to come? And the person who's feeling pretty depressed is like, nah, I don't feel like it, right? Because they have that lack of energy, that lack of interest. And so a couple days later, friends text again, and they're like, hey, we're all going rock climbing this weekend. Do you want to come? And you're like, no. And then the next weekend, hey, we're all going to go hang out at the park in a socially distant, appropriate ways with our masks on. Do you want to come? No. And eventually your friends stop texting. Because how many times can you say no before they're like, screw it, you're not interested in being our friend anymore, or you're not interested in hanging out with us? And what your friends don't know is it's not you saying no, it's the depression saying no. The depression is leading you to withdraw, is leading you to just want to sleep or just curl up on the couch and throw something on Netflix but not even pay attention to it because paying attention is too much work. And so then you feel isolated, but you were withdrawing. So now people stop inviting, and now you're isolated, and now you feel worse. And so that's sort of how that little circle goes. Okay. Family problems, conflict is quite common within the family. It can be quite challenging for a family when there is someone who is feeling depressed and exhibiting those symptoms of depression. Parents can find it quite frustrating when they're like, hey, you need to go do this thing, and their child is like, no, I don't feel like it. Hey, you used to love soccer. Hey, do you want to go, to your favorite restaurant? No, it's too people-y, right? So parents get frustrated and then that can create tension within the family. Again, thinking back, I know I've talked about this before, this idea that families like balance. When someone's out of balance, it throws the whole family system out of balance, and we can start to see some problems developing within the family unit as well. And then, of course, we do have to talk ever so briefly about depression and suicide. 60% of children and adolescents who are depressed think about suicide, and about 30% of adolescents who are depressed will have attempted suicide by the age of 17. So it's not something we can ignore. It's not something we can say, oh, kids don't do it. They do, and it's unclear when children die, sometimes in accidental ways, whether it was intended as a suicide or not. And part of it is we don't always know if children, so again, really focusing on children here, if they are able to cognitively realize that what they're about to do is permanent, right? So I can remember when I was living in upstate New York, there was actually a time when a fourth grader, so a child who was like 9 or 10, died, and it was reported as an accident, but the rumblings around town were that it was actually a suicide. And the question was, did he realize that it would actually be like permanent death, not just something that would elicit a response from other people? And that's the piece in children that we're not sure about. And so I think, number one, and a 10-year-old doesn't leave a suicide note. So we really don't know. And so I think oftentimes with children and younger adolescents, we sometimes see deaths that appear to be accidents that may have actually been suicide. However, the child or the adolescent may not have actually wanted to die. One of my professors in grad school, I remember, reported on a child who had attempted suicide by jumping off the roof of their 2-story house. Now, most people would know, most adults would know, you're probably not going to die if that happens. Break an arm, yeah. Break a leg, yeah. Crack a few ribs, for sure. But to the child, it was, I want to die and I'm going to jump off the roof of the house, but without the recognition that that wasn't a far enough jump, which sounds terrible and callous, and I apologize for that, but without realizing that, and I'm not going to tell you how many stories you should jump from, because that's just wrong, but that's where children might not always recognize. So they have the intent, but they don't really have the means, or sometimes they may have the means even though the intent isn't really there, but there's just no opportunity to go back. There's no do-overs. And we do know that 30% of adolescents, or children and adolescents who experience depression, will attempt suicide by age 17. So it is something we really do need to take quite seriously. In terms of the causes of depression, of course, we always have to look at genetic and family risk. We know through twin studies and through adoption studies and looking at parents that there is a genetic risk, there is a family risk. I'm just seeing I have a note here to look at page 333 of the text. So I'm kind of curious about what's on page 333, and I'm guessing it's something I wanted to share with you. I like when I leave little notes to myself, but with no explanation. It probably also makes it seem to you like I have no idea what I'm doing, but hey, I have a vague clue, or at least a little bit more than that. And so on page 333 of your text, what you will see, oops, as I just hit the mic with the textbook, is this little visual on a developmental framework for depression in young people, and it kind of looks at all the different pieces that go into it and how they can also go out of it. So just take a look at that. We'll cover a lot of that as we go through, but just take a quick look at that as well. In terms of neurobiological influences, there are many. Of course, we know serotonin, of course, is a factor. And then serotonin, of course, regulates dopamine and norepinephrine. So those also, so some of the medications target serotonin, some of them target norepinephrine, some dopamine, some combination of all three. But that certainly can be a factor. Family influences, we have to think about this in two different components. So when children are depressed and when parents are depressed. When children are depressed, we tend to see that parents engage in more critical and punitive behavior towards the child than others. They tend to have a little more anger, conflict, less warmth and support, and higher stress levels. Having a child who is depressed can be a really difficult situation for parents. Again, there's no manual that's given to parents that says what to do if your child is depressed, what to do if your child is suicidal. We know if your child ingests a poison, call poison control. We know if your child has broken an arm, take them to the hospital, have it x-rayed and casted. But what do you do if your child's depressed? Do you ask them a lot of questions? Some parents say, well, no, if I get too involved, I'm going to drive them away. They're going to shut down. They're not going to talk to me. Do we back off and say, okay, we're going to let them do their thing? Okay, well, now the child is thinking, why don't my parents love me? Why aren't they concerned about me? Why aren't they asking me what's going on? Do we right away take them for evaluation and help? And then the child's thinking, God, my parents are overreacting. I can never tell them anything. They're just going to take me for help right away. Do we just sit and let it bide some time? And then the child or adolescent is thinking, oh my God, do my parents not care? Like, here I am practically screaming out, I'm in pain. And they're like, well, let's just wait and see what happens. So parents can feel like they're in a no-win situation, that no matter what choice they make, it's the wrong choice. And so that can be really challenging for them. And so they try different things, but that are perceived by their child or adolescent as the completely wrong thing, or as not doing anything, or not doing enough, or doing too much. And so there can be anger, there can be conflict, excuse me. And then, of course, lots of stress. When parents are depressed, so this is parents being depressed in addition to their child being depressed, that interferes with the parent's ability to meet the basic needs of their child. In particular, maternal depression increases the risk of depression for a child. So if a parent is struggling with depression, it can be really challenging for them to meet their child's needs. It's hard enough for them to get out of bed in the morning, let alone be fun for their child. So that's when a parent ends up being like, hey, you're old enough to pour yourself a bowl of cereal and there's milk in the fridge. Except then the child at one point is like, hey, mom, dad, there's no more milk in the fridge, or we're out of cereal, or yeah, I'm old enough to pour cereal into a bowl and milk, but like we have no more bowls, right? They're all dirty and I'm not tall enough to reach the sink to wash them. So it's not parents willfully neglecting their children, but it's through their lack of ability to get through the day because of their depression, and then that puts their children at risk. The children are then not supervised, not feeling like they're getting that experience, not getting their needs met by their parents. So we really want to be cognizant of that as well. When we're treating a child, we want to also be sure to be checking in with the parents on how they're doing and making sure they're getting the support they need as well. Not surprisingly, stressful life events can contribute to the onset of depression. Now, keep in mind that DSM-5 does have a few other sort of categories. So if someone is experiencing depressed mood in relation to a loss, we'll look at bereavement, which is a V code, so another condition of clinical attention, but not flat-out depression unless the bereavement becomes complicated or it's gone on too long. But we certainly expect after a loss for there to be a period of sadness. Same thing with like a major event like moving, right? Moving to a different country, moving to a different house, changing schools, things like that. A parent who used to be a stay-at-home parent going back to work, those would all be more adjustment disorders as opposed to major depression. But again, up to a certain point. If we cross the threshold in terms of how long it's been going on or how severe the symptoms are, then we might look at depression. So we want to be aware that stressful life events can, stressful things happen. Sometimes our ability to cope with them is not what we need, but we have to remember, is it a grief response? So is bereavement a better fit? Is there a major adjustment that's happening? Is adjustment disorder a better fit? Or has it gone on with sufficient intensity for a sufficient period of time that now depression is the better explanation for it? And then emotional regulation plays a role as well. Children and adolescents who are experiencing depression can find it difficult to regulate their moods. It's not really a big surprise. And that could come first. So it could be that they're having trouble regulating their moods and that leads to depression. It could be that they are becoming depressed and therefore having trouble regulating their moods. Reflection question number 3. Imagine that you are a parent struggling with depression. I hope that none of you will be parents struggling with depression. But imagine that you are. So imagine that you're a parent. I know many of you aren't. Some of you are. I'm hoping that most of you are, or I hope all of you are not struggling with depression. If you are and you need help with resources, let me know. I'll connect you. But if you were a parent and you were experiencing depression, what would you personally do if your child was showing signs of depression? So just think about that. What would you do if your child was starting to show signs of depression? Okay, in terms of treatment of depression, hey, I'm a psychologist. I'm going to go for psychosocial interventions first, right? So number one, I want to make it clear that there is no one magic bullet for treating depression. Therapy is not the answer to everything. It's the answer to a lot of things, or it's part of the answer to a lot of things, but it's not always going to be the best fit or the only fit. And that's a really important thing to keep in mind. I can remember as a new graduate student in clinical psychology, I was of the therapy can fix anything. And then I got into my first practicum and I went, no, it can't. So I realized over time that there is very much a time and a place for other interventions, but psychosocial interventions are always a good place to start, okay? Cognitive behavioral therapy in particular is the gold standard for treating depression. Now in younger children, that might be more challenging because of that cognitive element, because we're trying to get children who don't really have a grasp on abstract thinking to think about their thoughts. So we might rely more on behavioral therapy at that point, right? So changing their behaviors might change the way they feel. We might use cognitive therapy without the behavior component with adolescents. And then also in the book, they do list some other variations that can be helpful with children. We'll also think about things like with children, play therapy and art therapy in conjunction with a psychologist can also be quite helpful. And of course, remember that for this course, for your big assignment, so the educational pamphlets, at least one person has depression and someone has bipolar as their pamphlet topics. And again, for your story, you can use any disorder you want, and some of you will probably gravitate towards depression. But there are different ways we want to reach children where they're at, so that might be different modalities that we take to get there. In terms of medications, SSRIs, so the selective serotonin reuptake inhibitors, are pretty much the first-line treatment for depression at this point. Prozac has been tested, I believe, in children as young as 6. It might be 12. I could be wrong on that one, but generally we do use SSRIs with children as well. And again, serotonin regulates our norepinephrine and dopamine, which are both implicated in depression as well. It's at this point that I would normally say, hey, let's talk about the article. What article, Carrie? This article. So the article on Blackboard that I'm expecting you to read before discussion is called Are Adolescents Dying by Suicide Taking SSRI Antidepressants? A Review of Observational Studies. So one of the things that happened when SSRIs started increasing in popularity is we started seeing an increase in the rate of adolescents who were attempting and completing suicide. And that got people all up in a tizzy, and now SSRIs come with what's called a black box warning, which is a reminder to physicians to make sure that they are following up with their patients after they start them on an SSRI. It's usually about 2 weeks in, and then again 6 weeks in, to make sure they're not experiencing any side effects or any bad side effects that aren't manageable, and then also to assess for suicidality. Now, the thing is, what we know about depression is that when people are at their lowest point, when they're at their most severely depressed, they're not attempting or completing suicide because they don't have the energy to do so. And we know that for anybody, as their depression starts to get a little bit better, that's when we're going to see a spike in suicide attempts and suicide completions. And it's because they now have more energy. And it sort of seems counterintuitive to think like, as you're getting better, that's when you think about killing yourself or trying to kill yourself. But what we often see happening is when someone is at that lowest point, they might be thinking about dying, but they have no energy to do so. They have no energy to form a plan, to go out and get whatever they need to enact their plan. And when they start to feel a little bit better, they've still been thinking about dying a lot. Now they have some energy to go out and do what they need to do. And they also have the thought of, oh my God, I can't believe how bad that was. I don't ever want to experience that again. I can't believe what I put my friends and my loved ones through. They'd be better off without me, which of course they wouldn't be, right? So we want to always be clear that no, the world is a better place with you in it than with you not in it, but it's hard to see that. And so what happened was when SSRIs became more popular, and especially as they were replacing therapy, we were seeing adolescents starting to suicide. And it became this, oh my gosh, this is a huge problem. The SSRIs are causing it. Well, maybe not. So read the article and be ready to discuss it when we meet. And then, of course, the other thing that we want to think about is prevention. So when we know that a child is at risk, so they have parents who have mood disorders, they have experienced some significant traumas or losses or stressors, if we can get in before before the depression takes hold, we might be able to avert that from happening. So we have some success with children who are at risk or already diagnosed but early on. Typically, it's using cognitive behavioral therapy and especially problem-solving skills. One of the things that happens is when we are in that low mood place, we're not using our problem-solving skills the way we should be. So by getting some CBT and some problem-solving skills, that can actually help prevent the onset of depression. And then finally, we're going to talk just very briefly about bipolar disorder, in part because we do see it in adolescents more than children. But again, now the mood dysregulation disorder is replacing, or not replacing, but the more appropriate diagnosis for some children and adolescents where they used to be diagnosed with bipolar disorder. In terms of the causes, bipolar disorder is one of those that has a very strong genetic cause. Genetics play a pretty big role. So I want you to think back to probably intro psych, possibly 2285, where you heard about the diathesis stress hypothesis, that we are all born with predispositions to different things. That's what our genetic code has. And if the right stressor or stressors should occur, that disorder will materialize. And so with bipolar disorder, that makes a lot of good sense that it has a strong genetic component, so people are born with the diathesis, and then that right stressful condition happens. The thing is, we don't know what that right stressful condition is, and it's going to vary from person to person, and it's going to depend on their resiliency, their resources, their supports, as to whether they're going to manifest the disorder or not. I've often imagined it would be wildly helpful if we all had like ticker tape coming out of our head with like, okay, you are one stress away from your schizophrenia gene kicking in. Or you can do cocaine 7 times, but that 8th time you're going to be hooked, right? So if we could know, because we have these predispositions and we just don't know. Like, we know that some people, the first cigarette they smoke, boom, they're hooked. We know other people who are essentially social smokers who bum a cigarette off a friend every now and then, but like never feel the need to smoke regularly. Some people, first time they shoot up heroin, it's too much and they die. Other people, first time they shoot up heroin, it's amazing, but now they're hooked. Other people shoot up heroin one time and are like, that was amazing, and then check it off my bucket list, shot up heroin, walk away. We don't know. We don't know what that right condition is to have something like bipolar manifest. So again, keeping stress levels low, having good coping skills, but even that might not be enough. We just don't know at this stage. In terms of treatment, this is an area where, contrary to what I usually do, we're going to go medication first, psychosocial second. Medication is often going to be a very important component in the treatment of bipolar disorder, and it is going to be part of the ongoing treatment program. So again, what we saw in Boy Interrupted was Evan wanted to try going off his meds, and that didn't work out so well. And his parents knew it wasn't working, and they had made an appointment for him to get back on it. Lithium is sort of the first line gold standard in people aged 12 plus. Younger than 12, we don't use lithium. And lithium, we have to be really careful because too much lithium can cause lithium toxicity. It can be particularly hard as well on a person's liver and kidneys. And lithium requires frequent blood tests to ensure that a person is within their therapeutic range, and also to ensure kidney and liver function. So pretty much liver, I think. I think kidney is less affected. So that might be a lot for a child. We have other medications that we use as well. Medications, interestingly enough, that were originally developed to treat epilepsy and seizures are quite effective in treating bipolar. I know, it's one of those weird ones. We don't really know why, except that the brain works in mysterious ways. Again, if you want to know more about the brain, please talk to Karen or Ev. Take Brain and Behavior if you haven't already. If you're in a 4th year class and haven't taken B&B yet, what is going on with you? right? You've got to take B&B. It's a second-year course. So we do see some success with that, and also our antidepressant medications, our SSRIs, but we have to be careful. Where we have to be careful is that if someone is getting too out of depression, it could trigger a manic episode in someone who's bipolar. So we have to be really careful with SSRI use in people with bipolar, but it is sometimes used and it can be quite effective. Psychosocial interventions, or therapy basically, is oftentimes, most times, if not all times, not going to quite be enough for people with bipolar. It can be very helpful. It could be really helpful in learning some of the skills that they might not have. Again, so that CBT, social skills, problem-solving skills. But it's also going to be helpful for any comorbid conditions. We often will see, particularly in adolescents, some substance use that goes along with bipolar. Either when they get into a depressive episode, they might try to use substances to try to get that high back. People who experience mania will by and large say they don't want treatment because they want the mania. The mania feels good, right? Now it can lead to serious consequences. There's risky behavior. There's things that a person can do when they're manic that can get them in trouble. But a lot of people don't want to give up the mania. They do want to give up the depression. They don't really like that. So it can be really hard to find that right balance. So another piece of psychosocial treatment is going to be dealing with any comorbidities, but also talking about the importance of maintaining treatment with bipolar disorder. Also can be helpful for the family, and then, like I was saying, for medication compliance. So, reflection question number 4. What are your thoughts on the use of medication for bipolar disorder in children and adolescents? And when you're done answering that question, that's it for today.